Thank you so much, Paris. I'll be talking about orbital rhabdomyosarcoma, which is the most common primary malignant orbital tumor in children. And it's the most common head and neck soft tissue sarcoma as well, and arises from the pluripotent mesenchyme. Generally seen in the first decade of life, and presents mainly with subacute proptosis that worsens in weeks, not in days. That is the common presentation in about 90% of children in our series. With downward and outward displacement of the eye, that is the most typical presentation because tumor is generally located in the superior, slightly towards the supranasal aspect. That was in 70%. This is one of the manifestations where a patient presented with a fleshy superior fornical mass, and when we do MRI, you see a superior orbital lesion in close association with superior rectus LPS complex and ptosis. This is a presentation of a botryoid variant of rhabdomyosarcoma in the inferior fornix. Now, on CT scan, it presents as a uniformly enhancing isodens well circumscribed lesion. It's fairly well circumscribed, as you see, but it is friable when you do surgery with no bone involvement, but excavation is present. As compared to the other side, you can see that there is a gentle excavation of the supranasal orbital wall. Contouring is present, and very rarely there might be intralesional cyst formation. That is mainly because of necrosis, and that may have variegated presentation. This is an MRI appearance of rhabdomyosarcoma, where its intensity is slightly darker to the brain tissue. It's almost similar to the brain tissue. Now, these are the differential diagnosis: granulocytic sarcoma, where child may have subacute proptosis. This child has subconjunctival hemorrhage and also had rod spots in the fundus. This is a child with non-African Burkitt's lymphoma with intracranial extension. Severe inflammation and lymphangioma with intralesional bleed can also mimic rhabdomyosarcoma. The first step that we take when we have a patient with rhabdomyosarcoma is to do an incisional biopsy. Like this child who has a superior orbital mass, we perform a multi-layered incisional biopsy. Just to show that superficial biopsy in this child showed only inflammation and fibrosis, and the deeper biopsy showed the tumor, that is embryonal rhabdomyosarcoma, which was desmin and myoglobin positive. So when you have a round cell tumor in children, there is an element of necrosis. The deepest component of the tumor may have necrosis. The intermediate part generally shows viable tumor, and the periphery is tissue reaction, peripheral inflammation with fibrosis. So if you take a superficial biopsy, you will end up with inflammation and fibrosis as the diagnosis, resulting in misdiagnosis and inappropriate management. So you have to go to the intermediate zone. That's the reason why we take superficial, middle, and deep biopsy right to the epicenter of the tumor. And spindle to ovoid cells in loose myxoid stroma is the description with the mitotic activity. Now, immunohistochemistry is mandatory in any round cell tumor, and rhabdomyosarcoma has a specific immunohistochemistry profile. In our series, we found embryonal was the most common variant of rhabdomyosarcoma, followed by alveolar. Pleomorphic is rare, and botryoid is the rarest form. We should not forget the associations of rhabdomyosarcoma, like from any familial cancer syndrome associated with p53 mutation, neurofibromatosis type 1, Noonan syndrome, Beckwith-Wiedemann syndrome, and Costello syndrome are some of the known documented associations of rhabdomyosarcoma, and these are to be looked for. Genetics is coming into rhabdomyosarcoma research very heavily, especially to identify chemoresistant and refractory variants. The management of rhabdomyosarcoma is mainly guided by the intergroup rhabdomyosarcoma studies. This was a very successful major study which has created several protocols for the management of rhabdomyosarcoma. It has resulted in success of multimodal treatment. And when we talk about management of rhabdomyosarcoma, it's generally after risk stratification as low to intermediate and high. That is based on the histopathology of the tumor and also the residual amount of tumor. If the tumor is completely removed, it goes to group 1. If there is microscopic residual tumor with involvement of regional lymph nodes or both, then it goes to group 2. And group 3 is gross residual tumor, and group 4 is distant metastatic disease. But in the orbit, we have to be careful in an attempt to completely remove the tumor. We should not we should not have damage to the extraocular muscles or loss of vision. So surgery could be incisional biopsy alone in a situation where the tumor is in a crucial location, debulking or excision biopsy, followed by histopathological confirmation of the diagnosis. Then we start chemotherapy, which is a combination of WAC plus IE, 3-weekly alternating, and that is followed by radiation. So after 3 cycles of chemotherapy, we provide radiation and provide 3 more cycles of chemotherapy. This is the dosage schedule that we follow. Vincristine, actinomycin D, and cyclophosphamide as one set of chemotherapeutic agents, ifosfamide and etoposide as the another set of chemotherapeutic agents, alternating 3-weekly, 3 cycles, followed by external beam radiation. If there is no residual disease at all in the orbit, just before you do external beam radiation, the dose delivered is 4,500 to 5,000 centigrade. If there is residual disease, then it is 5,000 to 5,500 centigrade. And whenever radiation is given, it is given to the entire pre-treatment extent of the tumor, not to the debulked or residual or to the post-chemotherapy residual. So treatment plan is based on the pre-treatment extent of the tumor. And in our series, we had a reasonably good outcome. Final visual outcome was as shown here. Majority of patients maintained reasonable vision. And regression in our series with primary treatment alone was in 86%. 5, of course, recurred, and they responded to secondary treatment, which was reinitiation of chemotherapy, and in 1 patient, exenteration and radiation. So at the end of follow-up, 97% had good outcome. They were alive, and 1 patient had succumbed to metastasis. This is an example of a patient where the tumor was around the inferior rectus muscle. The muscle was not seen. There was restriction of ocular motility. So this is one example where we do limited debulking or near total excision, leaving a part of the tumor behind. As you see here, if this was the inferior rectus, we left a part of the tumor along with it. That is the wedge that has been created, and rest of the tumor has been removed. So the residual tumor obviously has to be treated, and that was treated with chemotherapy, stereotactic radiation, and further chemotherapy. There's a patient where the tumor was around the superior rectus LPS complex, so it was nearly totally debulked, followed by further treatment. And this child, you can see a good outcome with multimodal treatment. His cornea has actually become much clearer after exposure keratitis resolved. This was one more child with multimodal treatment. This child was able to maintain his eye, but had lost vision because of prolonged disc edema and optic atrophy. This is a child who had to undergo orbital exenteration. Even in this situation, we chemo-reduced the tumor to the extent that we can do a safe orbital exenteration possibly with lid sparing, so that we can use an exenteration prosthesis that can be very easily mounted. One more patient with resolution following multimodal treatment. So in all, we had 97% patient survival. This is as compared to the IRSG data and the SHIELDS study earlier. We seem to have a slightly better survival. And although our follow-up is lower, average follow-up is 3.3 years, their follow-up was much higher. In rhabdomyosarcoma, we realized that most of the metastasis occurs at a mean period of 36 months. So our follow-up is still good enough to say that the multimodal treatment has a better outcome than conventional treatment. So in conclusion, I would say that multimodal treatment, including initial surgery, which is guided by the extent of the tumor, with an aim to preserve function of the eye as much as possible rather than complete removal of the tumor, followed by multi-drug chemotherapy, which is a combination of WAC and IE alternating, and stereotactic radiotherapy, provides excellent chance of local tumor control and life salvage in cases of advanced rhabdomyosarcoma. Thank you.